Welcome back to The Exam Room, a podcast where we dive deep into the world of value-based care, patient-centered healthcare, and improving health outcomes with your host, Dr. Rhiannon Winsor. Dr. Winsor is a certified surgical technologist, healthcare educator, and the manager of training at VB Care Network. With almost 30 years of experience in healthcare and instructional design, she's spent her career helping clinicians and care teams optimize patient outcomes.
Today in the Exam Room podcast, we're joined by Dr. Andy Mayberry, a family physician with Chiricahua Community Health Centers in Cochise County, Arizona. With more than 2 decades of experience caring for rural communities, Dr. Mayberry brings a deeply personal perspective on prevention, early intervention, and the importance of patient relationships. In this episode, we talk about managing high-risk patients, from understanding RAF scores to tackling lifestyle-driven risks like smoking and chronic disease. Dr. Mayberry shares real stories that show how small, persistent conversations can save lives, and why prevention, though less flashy, is often the most powerful medicine of all. I thoroughly enjoyed this discussion, and I'm sure you will too. Let's get into it.
Today we are back in the exam room, and with me is our guest, Dr. Andy Mayberry. Dr. Mayberry is a family physician with Chiricahua Community Health Center, a federally qualified health center in Cochise County, Arizona. He has worked in Benson, Arizona since completing his residency in 2000. He was in private practice for 17 years, then worked for a hospital-owned clinic for 3 years before joining Chiricahua. He has been with Chiricahua for the last 5 years. He has deep roots in the area. His family has been farmers and ranchers in Cochise County since 1877, and he was born in the Benson Hospital. He is also very interested in disease prevention. And today our focus is on managing high-risk patients. Welcome, Dr. Mayberry.
Thank you. Happy to be here.
Yes, thank you so much. Could you start by sharing a little more about your background, if there's anything else that you would like to share, and your healthcare journey?
Yeah, as you said, I'm from Cochise County, born technically in Benson, raised in St. David, which is a small town just down the road. Graduated from high school, went off, got my education, came back 14 years later after completing undergraduate, medical school, residency, and my first real job was in private practice. I was in practice with my brother and brother-in-law. My brother was a family medicine doctor. My brother-in-law was an internal medicine doctor, and the three of us ran a clinic for several years until we sold that clinic. And now I'm in an FQHC, like you said. I mean, the nice thing about living in a small town is where everybody knows everybody, and you can kind of see when you make a difference, that you see the person that you made such and such a diagnosis with, and people know you. I still have a patient thank me. He was a guy who did not want to get a colonoscopy, and I walked him to the front and I told one of my office staff, call this number, schedule his colonoscopy, do not take no for an answer. And I turned to him and I said, you will be getting this colonoscopy. He was somebody who I knew well and I could do it. He ended up getting the colonoscopy, ended up having a polyp. Gastroenterologist told him that if he would not have gotten that colonoscopy, that polyp probably would have turned into colon cancer and he would have died of colon cancer. I actually saw him at church last week, and he's somebody who I know in the community. When I would come home from work, my wife would ask me, so how was your day? And I would say, saving lives, stamping out disease. And that was just kind of my standard thing. And one of my daughters, when she was older and she'd talked to several people and people who I had helped, she's like, I thought you were joking. You really do save lives and stamp out disease. And I'm like, yes, I do. That's my job. And I think preventive is where you don't get the immediate, satisfaction, but you get kind of the long-term satisfaction out of knowing that you're making a difference.
So what led you to focus on high-risk patients and the challenges surrounding their care? Is there a high-risk category that comes to mind, like as far as chronic care, high-risk, multiple morbidities?
There's several. So I guess probably number one, probably the highest risk category are the people who are making lifestyle choices that are not compatible with longevity, like cigarette smoking and that type of stuff. The big thing on cigarette smoking is never give up as a provider. Never give up on these people. I remember specifically one patient that came in And I would bring it up every time. I try not to be confrontational. And he came in and I asked him, he was there for his annual physical, and I said, so when do you think you're going to quit smoking? And he said, probably about the second shovelful, meaning he's going to be dead in the coffin and the second shovelful of dirt that goes into the grave, that's when he's going to quit smoking. And I'm like, okay, great, that's fine. Whenever you're ready to quit smoking, let me know. I think I have some things for you. And he was somebody who, other than being a cigarette smoker, really didn't have any health problems. Saw him the following year, and he had quit smoking. And I'm not going to take full credit for that, but the fact that you bring it up in a non-confrontational way, let them know that you're there, let them know that that's important to them. So that's probably the number one category, is the cigarette smokers or the substance abusers, people who are drinking too much alcohol, those type of things. I think we can make a big difference by bringing it up. Don't ignore it. Don't assume that they're never going to quit, because like this one guy who made it very clear to me that he was never going to quit, actually within a year quit.
I was just thinking your story made me think of my grandfather several years ago. He was scheduled for a aorta bifin bypass, and him and my grandmother both smoked. And at midnight, my grandma said at midnight, like before his surgery, my grandpa was smoking his last cigarette because the doctor said, you need to quit. And she said, I don't care if you have to quit. I'm not quitting, and he quit. But he was still smoking a cigarette at midnight before he had his surgery. But then he did end up quitting. And I was just wondering, is there some key that caused that trajectory? Like, is there...
just the old concept of an ounce of prevention is better than a pound of cure. So I would much rather get a person to stop smoking than to have to tell a person that they have lung cancer. I would much rather deal with that. And that goes for all kinds of prevention. I would much rather prevent the heart attack than have a patient have a heart attack and those type of things, and colon cancer and breast cancer. I tell my patients, people talk about, oh, I wish there was a cure for cancer. I wish there was a cure for cancer. And we're talking about, finding a cure, blah, 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 all this stuff. There is a cure for colon cancer, and that cure is getting your colonoscopy at age 45, finding the polyp and getting that polyp removed, and you never get colon cancer. That's the cure for colon cancer, rather than waiting until you have a bowel obstruction and then go in and find out you have a 10-centimeter mass and it's already metastasized to your liver. That's very upsetting. And the thing with preventive care, it's not flashy, it's not exciting. You're never going to see a news story about a person who had a polyp removed. You are going to see a news story about somebody who had colon cancer and they've survived this long and they're on chemotherapy and their wife is really sad and all those things. That's the exciting stuff that people are drawn to. Again, living in a small town and seeing the people who you deal with and seeing that guy at age 35 and remembering that you took care of his father who had colon cancer and saying, oh yeah, your father had colon cancer, and so you probably ought to get a colonoscopy. You know what I mean? And so that's satisfying to me. And anyway, that's what led me down that road. And I think that it's self-evident that prevention is always better than treating. And maybe a little bit boring, maybe not as flashy and exciting, but for me anyway, in the long term, very, very satisfying.
I'm on board with prevention all the way. So we're focusing on our discussion on high-risk patients. Is there a definition that you have of what a high-risk patient looks like?
So I like the RAF score personally. Basically, depending on several factors, this person gets, adds to their number of what their RAF score is. And so the average person or the normal person over the age of 65 is 1.0. So if you're healthier than average, you'll be less than 1.0. If you're less healthy than average, then you'll be 1.5 or 2.0 or something like that. And if somebody has a condition that makes them more at risk, like type 2 diabetes, atrial fibrillation, or whatever, it kind of adds to their score. And so you can have somebody who has only one medical problem, they're not quite as high risk. You can have somebody who has one severe medical problem and they're high risk. Then you can have another person who has several smaller problems and that makes them high risk. And I don't use this exclusively or all that much, to be honest with you. It's more of kind of a gestalt type of thing where I can kind of tell who's high risk and who's not. But ideally, and we're not there yet, so our EHR calculates the RAF score, and I realize there are many things that go to the RAF score, like demographic information and all that kind of stuff, which we don't have. Our EHR calculates it only from the perspective of their medical problems. And if they have a RAF score below 1.5, I consider them kind of average risk. So 0 to 1.5, I consider them average risk. If they're 1.5 to 2.5, I consider them medium risk. And if they're greater than 2.5, I consider those people high risk. And one of the most important things, in my opinion, for a high-risk person is increased face-to-face time with their provider. So suppose somebody has atrial fibrillation and diabetes, and their RAF scores, I don't know, off the top of my head, probably 2.6 or something like that. That person probably ought to be seeing their provider once every 3 months. And so we're working on this, and I don't want to make it sound like we've done this yet because we're trying to get toward that. What I would like to do is I would like to set up a system where all of the people who have a RAF score of greater than 2.5 are automatically called in for an appointment at least every 3 months. That person is sitting in front of a provider, even if they're asymptomatic, even if they don't need a refill of their meds, even if they don't have a cough, even if they don't have a headache, even if their blood sugars are normal, that person needs to see their provider. Because so often, in my opinion, the provider has the ability to predict the future a little bit and kind of say, okay, you have proteinuria, we probably ought to start you on a medication to protect your kidneys a little bit, and that type of stuff. And so to answer your question, what do I consider a high-risk patient? So a high-risk patient is, for starters, anybody who smokes is clearly a high-risk patient. Now, does that person need to see me every 3 months? Probably not, but that's a high-risk patient. But for people who have medical problems, diabetics, I consider those high risks, especially uncontrolled diabetics, people with chronic kidney disease, those type of people, and they need to see me at some frequency. And if they have a RAF score of 1.5 to 2.5, they need to see me, in my opinion, at least every 6 months. If they have a RAF score of 1.5 or 1.49 or less, once a year is probably fine. If they're 1.5 to 2.49, then they probably ought to see me at least every 6 months. And ideally, the system would be set up to call those people in to see me. Then if they have a RAF score of over 2.5, they need to see me at least every 3 months. And so just get them in there, make sure that their meds are up to date. And so often, you think that people are on cruise control, and you bring them in there, they have chronic kidney disease, they have congestive heart failure, they should be on Entresto, or they should be on an ACE inhibitor, and you bring them in and you review their meds, and you're like, oh, you were on lisinopril last time I saw you. You're not taking your lisinopril anymore. Oh, because my sister told me that was for hypertension, and I don't have hypertension. My blood pressure is normal, and so I quit taking that. And you're like, well, actually, it's to protect your kidneys because you have chronic kidney disease. It's also because you have congestive heart failure, and this has been shown to be beneficial in people with congestive heart failure. So how about if we start you on that again? And that type of stuff. And so often you think you have everything on cruise control, you think you have everything going fine, and something happens. They quit taking their medication, they, I don't know, whatever, lost their medication, and they just need, these people need to be kept on, I call it a little bit of a shorter leash. And I think that there's probably a certain age that somebody ought to be kept on a shorter leash. My patients, myself personally, I'm not going to say that everybody needs to do this. I tell my patients when they reach the age of 80, even the healthiest person in the world over the age of 80 probably ought to see me twice a year. And over the age of 90, the healthiest person in the world over the age of 90 probably ought to see me 4 times a year. And so those are the high-risk people.
So as you're working on getting this automatic system set up, you're taking on that responsibility of saying, hey, assessing the patient's RAF and saying, hey, I need to see you in 3 months. Schedule this.
Right. So when I finish my appointment with them, I say I do have a system where I put in the system to have this patient rescheduled in X number of months. And so I do that. My fear is, so I'm seeing Mrs. Jones. Mrs. Jones is high risk. She has diabetes. She has heart disease. She has atrial fibrillation. She has whatever else going on. And I say, okay, Mrs. Jones, you're doing pretty well today. Your A1C could be better. It's 7.6. We'd prefer it to be closer to 7.0, but that's not terrible. Here's a refill of your meds, and you're up to date on your mammo and everything like that. Okay, make an appointment. I'm going to ask my staff to give you a call in 3 months to make an appointment. Oh, great. And so the staff calls her in 3 months, or calls her to make an appointment in 3 months, and then something happens. She forgets. Her dog got sick. She had to take her dog to the vet or something like that, or her car broke down, and so she cancels the appointment. There's no system set up to catch that currently. And so if it works great where I see them, we schedule the appointment, and that works all the time, that's great. And I find that sometimes Mrs. Jones calls in for a refill of her meds, and in my mind, I'm like, I haven't seen her for a while. Look at her chart, and I haven't seen her for 6 months. And then I have to reinitiate the system for them to call her and to get her in. It would be ideal if that happened behind the scenes, because I'm afraid that I'm going to forget or miss something. But currently, it's up to me. Currently, it's up to me. I would like some help on that. We're working on that. We're working on a system.
So I'm assuming that these high-risk patients are also seeing specialists?
Most of them, yes. And that's a difficulty. That's a difficult thing as well. I just saw Monday, a diabetic patient. He's like, my endocrinologist sees me once every 4 months. Why do I have to come see you? And I'm like, well, because your endocrinologist isn't ordering your colonoscopies. Your endocrinologist isn't. And so we negotiated, and I lost the negotiation, and he's only going to see me once a year. But
so how do you keep track of all of that? Like if you have a patient that has 3 different chronic conditions and they're seeing a specialist for each of those, like how do you capture that information?
It's difficult. It is difficult. For one thing, each specialist sends us a record when everything works properly. Mm-hmm. There's some specialists who have some moral objection to sending records, ophthalmologists especially. Don't know why ophthalmologists just do not want to send records. They just won't do it. I mean, you'd think I was asking for their tax returns. They do not want to send records. And so I have a hard time getting the ophthalmologist to send records. But in general, the cardiologist is really good. The pulmonologists are good. The endocrinologists are good. Gastroenterologists are good. That when they see my patient, they send me a record. And so I get that. And then, of course, when I see the patient, I follow up with them. Nephrologists are good. I follow up with them. I say, okay, you have chronic kidney disease. You're seeing a nephrologist. You've had a heart attack. You've had 2 stents. You're seeing the cardiologist. And then they'll say, oh, no, I haven't seen my cardiologist for 5 years. I'm like, probably ought to see your cardiologist. If you've had stents, probably ought to see your cardiologist once a year. And then I will renew that. I'll renew that referral. But for the most part, I get the consultation reports, and then also I talk with the patients about, are there any concerns? Is there anything that the kidney doctor told you that I need to know, or anything like that?
Sometimes it's hard too because patients might not know. I go with my mom to see her nephrologist, and if I wasn't there, she wouldn't, she just gets so scared. So she doesn't remember anything that the doctor says. So then when we leave, she's like, well, what did he say? I'm like, he said everything's good, Mom. Or, your GFR is a little bit low, you need to drink more water, or whatever, but she won't know to communicate that to her PCP.
And that is usually communicated via note, and so you'll see the note, and look through the note. And this is probably not very polite, but when I was in medical school, somebody told me this unfunny joke. What's the difference between pediatrics and geriatrics? With pediatrics, you have adult supervision, and so with geriatrics, you don't have somebody there. You don't have somebody to help them navigate the system. You don't have somebody to interpret. You don't have somebody to explain. You don't have somebody to advocate for them. Of course, in your mom's situation, she's lucky that she has a daughter who's here, who's available, who's interested. That's not very common. Maybe it's common, but it's not 100%.
Yeah, and even though they send a note through her portal, she doesn't know how to access that. Like, my stepdad knows how to access that. I know how to access it, but she isn't tech savvy. Right. So she wouldn't be able to get to that anyways.
Right.
So yeah, I think having an advocate, it sounds like you're a big advocate for your patients too.
I try to be. I mean, of course, there are people who fall through the cracks and things like that. But the chronic care management system, the Medicare's chronic care management program is awesome. I love that because we have somebody who's a medical professional kind of watching that patient and being aware of that patient. So when an appointment falls through, they catch it. When a patient needs a refill of a med, they go and they look in the chart and they say, oh, she needs a refill of her diabetic meds. Oh, her A1C was 8.5. Oh, she hasn't been seen for 6 months. And then they remedy that. And so I love the CCM program. I wish we could put everybody, I'm serious, everybody on CCM. I feel like that's, if I were the boss of the world, or, if I could be in charge of Medicare, I would make that where the real money was being spent was in the CCM program, because that is so helpful.
Thank you for joining us in the exam room, where we examine the vital signs of value-based care and diagnose what's shaping the future of healthcare. We hope this conversation was as insightful as your last checkup. A big thank you to our guests for sharing their expertise and prescribing actionable ideas. Stay tuned for more episodes as we probe the topics that matter most in value-based care. Until next time, take care, and thanks for listening to The Exam Room.